What does the longest serving health secretary think of our NHS? What do you say when interviewing one of the most divisive characters in modern British healthcare? Sir Jeremy Hunt was the longest serving health secretary who in 2022 was appointed Chancellor of the Exchequer, becoming the only person in British history to have both been health secretary and chancellor. Finance and health, two seemingly incongruous ideals with no shared geometry, form or function. One incessantly strives for growth, values abundance and awards individualism, whilst the other champions human well-being, struggles with resource scarcity and understands healing as a common communal effort. What sort of man is able to lead both? What are his ideals, cares and concerns? I sat down with Sir Jeremy Hunt principally to learn more about his book, Zero, Eliminating Unnecessary Deaths in a Post-Pandemic NHS. I wanted to know why championing patient safety of all things became his personal campaign. I also wanted to know what were his learnings in both of his roles in leadership. There is a verticality to this conversation. We're about to go to the upper chambers of political power to sit with a health leader and listen to his unfiltered thoughts and views, and hopefully hear the unheard. From Medicine Unheard, this is Sir Jeremy Hunt.
Well, thank you for having me, Hamad. It's a real pleasure to join you on the podcast. And what was my motivation for writing it? Because I felt when I was health secretary, conflicting emotions about the NHS. I felt this tremendous support for the founding values of the NHS, the idea that we should have a health service, which it doesn't matter whether you're rich or poor or young or old, you can always access the healthcare you need. Contrasting very strongly with countries like the United States, where you've got 30 million people uninsured. And so that for me was something that's one of the best things about Britain. But at its worst, the NHS turns patients into numbers and doesn't treat people with the humanity that most doctors or nurses would want. Now, I say at its worst because the vast majority of the time, the NHS does a brilliant job. But I wanted to write a book that tried to understand why that happens and what we could do to avoid that. And I focused on patient safety, which was one of my big passions. But I really see patient safety as a Trojan horse for looking at the whole issue of quality. So I think the NHS, there's a lot of focus on waiting times and output and doing as many operations as you possibly can get through in a day if you're a surgeon and so on. And sometimes quality is what goes missing. And I sort of think as quality and safety as two sides of the same coin. And the reason that this became something that I focused on was because just within a few months of becoming health secretary, I had to deal with the mid-staff scandal. And I was shocked to the core that inside the NHS, patients could be treated so badly. And what it boiled down to was that the NHS under the Blair and Brown governments improved dramatically, but there was this big focus on targets and becoming foundation trust. And, some managers interpreted what they were expected to do radically the wrong way. And we ended up with mid-staffs, but we also ended up with pockets of mid-staffs across the NHS. And so this book was it's the book I wish someone had given me the day I became health secretary, because, I learned so much over that 6 years. And of course, the great sadness in politics is some of these things you don't learn till the very end, but that was why I wrote it.
You write very early on that ultimately it's not about rogue staff or a rogue hospital that precipitates these preventable deaths and patient safety concerns. It's really a rogue system that you, as the longest serving health secretary, had to sit on top of. Looking back, what do you now see as your greatest responsibility and limitation as the health secretary sitting on top of a system that was fallible or failing?
Well, the problem is that every health secretary arrives and they feel that the system is failing to do what we want it to do as a country, and they decide that they're going to be the one that fixes it. And the top leadership of the NHS is incredibly well versed at coming to a health secretary and saying, what do you want to do? you want to return a waiting list to 90% of patients being seen within 18 weeks. We can do that within 4 years. Here's a plan, and it's going to cost you, 33 billion quid or whatever the number is. And so there's this very strange system, and the people at the top of the NHS are very capable and very competent. And actually, a lot of them, if you give them the 33 billion quid, they will actually deliver that plan, although not always, but very often. But then that same health secretary gets to the end of their period and they find either that they haven't delivered the plan they wanted to, or that they have delivered the plan, but some other things have gone wrong, which are really awful and actually the thing that everyone's talking about. So if you remember, Tony Blair's objective when he became Prime Minister was to bring down waiting lists, and he introduced the 4-hour wait and the 18-week elective care waiting lists. And he delivered those by 2010. But then we had a whole bunch of other problems in the NHS, including Midstaffs, Morecambe Bay, as we subsequently found out, Shrewsbury and Telford, East Kent, and now Nottingham, a whole bunch of other patient care scandals. And I think that the NHS has got too big. And I think that what happens if you have a big system is that it's the biggest healthcare system in the world, and it's run with targets coming out of its ears. I mean, Stalin would be proud of the number of targets that a hospital will have, 30 or 40 targets. A GP will have 70 targets. I mean, the trouble with that many targets is that you might as well have no targets. And what it actually does is it disempowers local managers, local innovation, and local decision making. And you get this kind of learned helplessness in the system. Let me give you an example. I'm talking to you from my office in Parliament, and I'm looking out of the window and I can see St Thomas's Hospital across the other side of the river. And, what would happen with a hospital the size of St Thomas's in any other country is that the management would come in and say, we've got to have a decent IT system to make this place run efficiently. And St Thomas's has, just in the last couple of years installed Epic. But it took them, probably 2 decades longer to do that than it should. And the reason is because the poor old chief executive is being played with monthly delivery targets. And, someone from NHS England is saying, what are you going to do in August and September and October and November for your cancer targets, your A&E targets? And everything becomes very short-term focused, and the kind of big long-term changes that you would see in hospitals in other countries, and for example in the private sector in this country, don't tend to happen. And the NHS ends up continually firefighting. So I don't favour dismantling the NHS, but I do think we should copy Sweden and run it in smaller size chunks that allow it to be more nimble and more flexible, possibly around the ICBs, but I would favour just devolving a lot more power down. And at a very local level, I think we should go back to people having their own GPs, with GPs having a group of patients that are their patients, like we have with the old list system. Because if there's one thing that could really personalise the NHS and stop this problem of patients becoming numbers, it is if there was one person in the NHS who you knew was responsible for your health and your family's health. And by the way, I think that would make GPs' jobs a lot more rewarding too.
Absolutely. Continuity of care, quite key, I think, in the motivations of primary care physicians, and they see value and benefit in seeing their patients and the outcomes too. You mentioned about plans and the rigor and the zeal of a new health secretary entering their role. That NHS 10-year health plan came and went just a few weeks ago. It sets out ambitions to make the NHS, and I quote here, the most AI-enabled care system in the world. What are your thoughts on its vision, if you had a chance to look at it? Do you see it as realistic? And what are the biggest opportunities and risks in pursuing AI-driven transformation? I know you also talk about it in your new book as well. Is the longest-serving health secretary pro-AI, or he has his reservations?
No, I'm very pro-AI. I think it's going to be completely transformational. I think that, you can actually see if you use ChatGPT that, there is so much knowledge on the web that you can get a very good and quick view, which sometimes will be wrong, but sometimes it'll actually be more accurate than your GP will give you. And I think it could be immensely powerful in getting patients the answers they need more quickly. So I think it's really exciting. I mean, the 10-year plan, it's an interesting one. I mean, it's basically, in terms of its strategic objectives, it's identical to the 2019 10-year plan that was published by Simon Stevens And I started work when I was health secretary. Actually, Matt Hancock was the health secretary when it was eventually published. And so I think that's a good thing that it's the same, because it shows that basically there is a consensus that we need to move care upstream. Prevention is better than cure. We need to go digital. And so I think that's to be welcomed, that it's not a sudden change in strategy. But I also think we should recognize that the issue is not the strategy. There is no disagreement about what a modern healthcare system should do. We should be treating people early so they don't need to go to hospital rather than waiting till they do need to go to hospital. But how do you make it happen? And the uplift in spending the NHS is getting 3% in real terms every year is almost identical to what it was getting in the last Parliament. And demand is going up by 3% a year anyway. So it's quite difficult within that very fixed pot of money to see how you're going to find the money for a big transformation of primary care services so that we're investing a lot of money upstream that isn't currently being invested upstream. So that is, I think, the challenge with the 10-year plan. It's going to be delivery. I think that's why there is some skepticism inside the NHS that it will end up being quite as transformational as the government makes out.
Let's then go back to the arguments that you've presented, or the concerns and issues that you presented with the NHS whilst you were leading it in your book. You argue that the covering up of mistakes and poor patient or substandard experiences of care that patients experience is endemic. Like you said, there's multiple mid-staffs, there's pockets of mid-staff. It wasn't just one singular event. And it's not just in the NHS. You said it's also in most modern healthcare systems. What are the most powerful levers, we think about legal, cultural, or structural, that could make candor the norm rather than the exception, create that cultural system change that you were seeking out to do with this book?
Well, the first thing is that the most important thing to recognise is that if we're going to avoid tragedies repeating themselves, then the NHS needs to be much better at learning from mistakes. And, this is particularly the case when you have a tragedy which involves someone, for example, dying, a baby dying in a maternity unit or becoming severely brain damaged. What you want is a system where because of medical error, a baby ends up being born brain damaged in Blackpool, those lessons are learnt by the NHS maternity units in Cornwall, and they're learnt quickly. And that doesn't really happen in the way that it should. It doesn't happen in our system, and it doesn't happen in very many systems globally. You will find hospitals that have a very strong learning culture inside the NHS, somewhere like Salford Royal. And then you get international hospitals that are very famous for this, like Virginia Mason in Seattle, that are very good at learning. And they have created a culture where staff are able to admit to mistakes without worrying that if they do, they'll lose their jobs. And that is a really difficult thing, because if someone makes a mistake, and particularly if there's been a tragedy involved, the easiest thing for the hospital to do is just to say, well, that doctor was a rotten apple and we fired them. And that makes life easier for everyone, because the patient feels, well, we were unlucky, but we've had justice. The doctor's lost his or her job. The hospital can just go back to being everything they did before. But if it was a systemic problem, and this was the issue we had with the Balagaba case, but there are lots of other examples, then of course that tragedy will repeat itself. It'll just be a different doctor or a different midwife or a different nurse next time round. And so we still haven't got over this problem that people worry that they will pay with their job for being too honest. And in particular, when it comes to the most expensive part of NHS litigation, which is maternity claims, because obviously if a child is born brain damaged, then that's an enormous challenge for the parents, who's suddenly going to have to look after a disabled child for their whole life. That wasn't in their life plan that was going to happen. There's a lot of costs associated with that. And they know that if they go to court, they could end up with a settlement, several £1 million, but it might take 5 to 7 years. Now, the problem is that when the doctors and midwives and nurses involved know there's a court case, then they're very nervous about speaking openly about what they think happened. And in fact, there was an example in Bristol where, a doctor spoke very openly to a father about a child that had died of sepsis, and then gave the opposite testimony to the coroner, because on lawyers' advice, she'd obviously been told that she couldn't say what she'd told to the father. Now, you can't possibly learn from mistakes if people are worried about speaking openly. So, like all health secretaries, I arrived saying, we're going to root out bad managers, we're going to dock their pay, we're going to get rid of, bad staff like the ones at mid-staffs who did these terrible, cruel things. What I came to realize over my time as health secretary is, of course, in an organisation of 1.5 million people, there are going to be one or two rotten apples. And of course, if you find them, you should get rid of them. But that isn't the problem the vast majority of the time. Most of the time, actually, mistakes are made that anyone could make. And what we need is a system that tries to make it impossible for those mistakes to be made.
You reflect also on the trauma of clinicians. Of course, the patient's caregivers, they're the primary victims. You mention clinicians as the secondary victims after patient deaths and describe the effects of litigation, as you just mentioned, and the blame and perhaps the changing of the testimony. How do you reconcile the need for accountability with the need to protect staff from a culture of fear, especially like the Bawa Garba case that you mentioned?
Well, I think that this is where the concept of a just culture is a very good one. So, I think there's two types of accountability. There's the accountability of a captain whose plane crashes because there's a mechanical failure that's not his or her fault. And that captain is still responsible for the safety of all the passengers on that plane. What you want is for the captain to feel they can be completely open about what happened so you can learn exactly what went wrong. And you need to have a system that treats that captain very differently to the captain that turned up to fly the plane drunk. And so in both cases, there is someone who is clearly accountable, but it's very clear the way we treat that person should be different in both situations. And I think that doctors don't have the confidence that the system will properly discriminate between cases when they are absolutely at fault and they do something they shouldn't have done, and the cases where they did their level best to do the right thing, but tragically things went wrong. And that's what we need to get right in our culture.
Your book is rich with stories of families that were forced to become campaigners. You mentioned Melissa Mead, Sarah Ryan, amongst others. You write that we put it on the shoulders of grieving relatives to push for change instead of building a system hungry to make such changes automatically. Why does the NHS still rely on external pressure for reform? What is it about its design and mechanism?
I think that one of the reasons is because we have a political system where politicians are very sensitive to public opinion. I think that's a good thing, by the way, not a bad thing. So sometimes relatives feel that they're going to they go to their MP, they might get more progress than going to their local hospital. I think sometimes, though, there is this institutional failure that we see in other parts of the British state where when something goes wrong, people close ranks. And sometimes there are reasons for that, like what we've been discussing, people worried about legal cases. But sometimes, I came across stories, really completely inexcusable stories, like, the story of Scott Morrish, whose son Sam died of sepsis in Devon. And when he tried to raise it with the local hospital, they point blank refused to meet him. And I actually went to that hospital and gave a patient safety talk there. And I came away really convinced that I was a bit nervous before the talk because I knew this thing had happened at that hospital. And I came away really convinced that they had thought hard about what happened and they really were determined to make sure it didn't happen again. But I think that, we have to be honest with the public that medical error is normal. It's just that the challenge in medicine is that sometimes the consequences are far worse than the errors that everyone makes in their daily lives in every other profession as well. And we need the public to understand this can happen, and we need the NHS to understand this can happen. And the duty of candour, which creates a legal obligation for hospitals to be open when something's gone wrong in someone's care, I think it's worked to a degree, but I don't think we've got there. It's certainly better than it was, and it's certainly the case that we are able to talk about medical error and mistakes openly, as we're doing now, in a way that would never have happened 15 years ago. So we are definitely much more open about when things go wrong. But I still think that it's too much of a battle for too many families to get to the truth. And that's what we still need to do a lot of work on.
You write in your new book, Can We Be Great Again, that, well, you reflect on the UK's crisis of confidence just in general and the importance of national self-belief, and you related it quite a few points. I sort of align that to perhaps a crisis of confidence within the NHS as well, and our sort of lack of self-belief now. How does this crisis manifest currently in the NHS, do you feel? If you feel it does at all, and what would it take for the health service to rediscover a supreme level of self-confidence, I think, as you say, is needed for Britain to lead globally, particularly in the healthcare and life sciences services?
Well, we've certainly got the potential in terms of the world-beating research that happens in the UK, the extraordinary caliber of our top doctors and top nurses. And I think that the underlying values of the NHS, the idea that we want to be a service that's there for everyone, is actually a very motivating set of values that many people inside the NHS strongly identify with. So there are lots of things going in our favour, but the truth is that the NHS has not really got back on its feet after the pandemic. That was the biggest shock in the NHS's history. The NHS did a very good job in making sure that every COVID patient that needed an intensive care bed got one. Everyone that needed a ventilator got one. We didn't in the end need to open the Nightingale hospitals. But the NHS did that because it stopped pretty much everything else. And other healthcare systems didn't do that. They carried on with their routine care and their cancer treatment and so on. And the result is that, unlike in France and Germany and the Netherlands, the NHS is now left with huge waiting lists, and that creates huge pressure throughout the whole system. So what do we do? What do we need to do to end that culture of defeatism? Well, I think what we need to do is to really march forward fast when it comes to reform. I think that we need to look at the big changes that would really turn things around, and it's always a small number of really big changes that are transformational in these situations. I think if people had their own GPs, if GPs were rewarded for keeping people out of hospital, so they basically, if they invested in primary care in their areas, and as a result the number of emergency admissions fell, they got money that helped fund the expansion of those services. That's a kind of really good way, a win-win way of getting everyone back. I think we should give much more autonomy to hospitals and ICBs and groups of GP practices to innovate. What I would say is that if you look in other parts of the state sector, we have shown how, with a publicly funded system, we can totally transform things. For example, state schools. I mean, I went to private school in the 90s, and middle-class parents would say in the 90s, if you can possibly afford to, don't use state education because you can't trust it. No one says that now. If you've got a school with a good Ofsted report, people think that's brilliant. And often the standards are high and even higher than independent sector schools. And so how do we transform our state schools? They have some of the highest reading standards and math standards in the world now, British state schools. And we did that because over 25 years, we gave maximum autonomy to head teachers, and we allowed local innovation to flourish through the academy chains. And we don't have any kind of national targets. We just have transparency. So the exam results are published, and your Ofsted report is published. But apart from that, basically it's up to you as a head teacher and up to the governors of a school. So that's what I think we need to do in the NHS. I mean, can you imagine if the Education Secretary had a target for the number of physics A-level passes next summer? The Department for Education would have regional managers picking up the phone to the heads of comprehensives saying, couldn't you get a few more people doing physics? And actually what it'd be doing, it'd be recreating NHS England in education. And you'd end up with all this bureaucracy and all this managing upwards instead of heads doing what they do in our system, which is actually spend all their time saying, how can I raise the standards in my schools? And so that's a really good lesson. We've done it for our schools. Now, hospitals and GP surgeries are more complex than a school or a university, but the principle is exactly the same. So I'm very optimistic that we could actually do this if we were bold in the type of reforms we introduced.
Just in this conversation, I realized you are uniquely titled as the only politician in British history to be both the Health Secretary, longest serving at that, but also the Chancellor of the Exchequer. Now, those two roles are perhaps butting heads at times with how much budget can the health sector actually take. Is it always outstripping the needs? And in the conversation of we have unsustainable demands, capacity is always going to be lower than the increasing demands of a growing population with ill health. And so we need to find sustainable ways. In comes the conversations around prevention, in comes the conversation about digital enabled health tech. First of all, just from your experiences in those both roles, what lessons have you learned and that can inform anyone else taking the mantles of the health secretary, or even just thinking about reform and budget and the finance to fund the reforms that we need in the NHS?
Well, it was really useful when I was Chancellor to have been Health Secretary, because I understood some things which I think other chancellors, inevitably because they weren't Health Secretary, didn't perhaps understand. So I understood that we have a historic problem, that we've not trained enough doctors and nurses. And I was really proud to bring in the NHS long-term workforce plan, which basically doubled the number of doctors and the number of nurses we train. Now that you won't see that on the front line for 7 years or so because of the time it takes to train a doctor, but I think that will be really transformational when it happens. I also recognise that because often the NHS is too short term, we've got behind on tech. And that was why in the budget last year, I gave the NHS £3.4 billion to totally overhaul their IT system. And that came alongside the first ever NHS productivity plan, in which the NHS committed to 2% productivity savings every year. And that 2% number, by the way, I didn't just pluck it out of the air. It was a very important number to me for a chancellor reason, because if we increase public sector productivity 2% a year across the whole public sector, even despite spending more on the NHS and despite spending more on health, our national debt would actually stop going up. And so at the moment, we have about 0.8, 0.9% annual productivity across the public sector. So you don't need to increase it that much to really transform the nation's finances. So if we're bold on productivity and innovation and digitization, we can definitely continue to fund the NHS. But if we don't change how we do things, then it will become very, very difficult.
Well, speaking in terms of productivity, in your new book, you also note that public sector productivity is still 7% below pre-pandemic levels, as you mentioned earlier, and nearly 20% lower, particularly in the NHS. You've mentioned some reforms that you'd like to do, but if we're particularly looking at the angle of productivity, what are some reforms that you think are most urgent to not just remediate and redress, but actually completely radicalize levels of productivity? Perhaps some that are blue sky thinking that excite you, or some that you think we should have had this 20 years ago and we still need it now?
Well, some of them are quite technical, so I hope your listeners will kind of bear with us. But one of the things looking at the school system that we should do is get rid of all the national targets, but say to an ICB, say it's Norfolk or Norfolk and Suffolk, look, here is 5 billion quid, and you've got total autonomy how to spend it, but you can't spend more than that. But that is your budget for the year. And, be innovative, be clever, work out how to deliver more for less, work out how to get more operations done in hospitals, how to stop people going into hospital, and do some really clever, smart things. And I think if you did that, what you'd find is that people did different things in different parts of the country, but there was a lot of innovation, and the ones that were successful, everyone else would copy. And that we don't have nearly enough of in the NHS, because everyone is waiting for their orders from NHS England. And so we've got the system where the people running all the ICBs are looking over their shoulder to their NHS England regional manager, who's looking over their shoulder to the NHS chief executive, who's looking over his shoulder to the Secretary of State. And, the thing that we really want, which is huge energy into innovation and transformation on the ground, doesn't happen in the way that it would happen in lots of other countries. I've mentioned going back to people having their own doctor. There was a study in Norway that said that people who have their own doctors for a long time are 30% less likely to go to hospital. Why is that? Because if you have a family doctor who knows you and knows your family, not only are they less likely to misdiagnose you because they understand the context, but they are also going to be able to have the confidence to say to someone, you don't need to go to hospital. You'll be absolutely fine. Just take the Calpol and, call me if it's not better in 3 days. But if you have a doctor who doesn't know someone, doesn't know a family well, they're going to be very much more cautious. And if they're not sure, they'll think, well, I better just get this person to go to A&E in case there's something going wrong here. And by the way, people have the same doctor. They're not just 30% less likely to go to hospital, they're 25% less likely to die. So it is actually safer care as well. So that seems to me to be something that would be very popular with the public. It would reduce a lot of hospital admissions, and I think actually would be well received by doctors as well. Those probably would be the two top ones at the top of my list.
Now, I guess we have to inevitably talk about what was a central episode, not just in your book, but also in your tenureship as the health secretary, which was the junior doctor strike. And you reflect that the main reason for the impasse and the sort of furor was probably a straightforward misunderstanding about your plans, and it was a serious failure in communication. Reflecting upon what has happened and what you've learned in your leadership, and particularly as health secretary, what do you wish you had understood about the profession's culture, about the culture of the NHS and anxieties before the dispute? And what advice would you give to the next health secretary, or even streeting now facing similar unrest?
Well, I think that, the first thing to say is that I got locked into a confrontation in which if I didn't win, I would have lost my job. And the junior doctors leader at the BMA, because they were called junior doctors, not resident doctors then, knew that he would lose his job if he didn't win. So literally, in a way, it's a bit like Putin and Zelensky. There's literally neither of us could give. And I got locked into that struggle very early on. So the first thing I would say is you need to be really careful before you get involved, because sometimes you might end up in a place where there's no exit. And in the end, I won, but it took me nearly a year to do so, and at the cost of a lot of relationships inside the NHS. And because I was very keen on patient safety, I'm sure it made continuing my patient safety agenda harder because there was so much ill feeling towards me. I think that the changes that I wanted to make to the junior doctor's contract were right, and no one has reversed them since, and they were needed to be made. But I think the biggest thing with the benefit of hindsight is if I was going to have a big battle, I should have had it with the consultants. Because actually what I really needed was more consultants in work at weekends. And the junior doctors already did quite a lot of weekends, and the contract changes made it easier to get more junior doctors in at weekends if that's what I wanted to do. But actually, the thing that would make the biggest difference to patients was more consultants coming in at weekends. And I should have focused more of my energy on the consultants contract rather than the junior doctors contract.
Do you have any thoughts, concerns, opinions about the current narrative around the industrial action that the BMA hopes to take, the narrative around pay restoration, or rather the pay degradation that hasn't been restored since 2008, concepts of poor experience of work or a working environment for a resident doctor? How do you rationalize that? What do you think about when you hear the lived reality and experiences of resident doctors today?
So when it comes to pay, I'm afraid I don't agree with the BMA, and I do agree with Wes Streeting. And I think that they pick this arbitrary date of 2008, I think it is. Well, that was when we had a global financial crisis, and everyone has seen their pay grow much more slowly since 2008. And, the reality is that although doctors' pay has also grown more slowly, you could pick a different date like 2015, 2016, and you could see that actually doctors' pay has grown pretty healthily since then. So it's an arbitrary date, and also they choose RPI inflation, not CPI inflation, which is the standard measure we use. And they choose those things carefully to make it sound like doctors are very hard done by, whereas actually, as a doctor, if you stick it out to becoming a consultant or a GP, you will have a six-figure salary, earning more than £100,000 and be in the top 2% of taxpayers. So I'm afraid I don't buy this argument that the pay is unfair. I think the whole country has had a tough time economically, including doctors. And, in the end, taxpayers fund the NHS and doctors' salaries, and they've had a tough time too. So where I think they have a point is that I think it is very stressful being a doctor, and it's very stressful being a junior doctor. And I think working conditions are very tough. And part of the reason for that is that we still don't have enough doctors. There are still too many rota gaps. And, it is going to take time for the big increase in doctors that we're going to see through the long-term workforce plan to feed through. There's no question about it. But ultimately, we're starting to train enough doctors to mean that the prospects for a doctor are of an NHS which is not overwhelmed by pressure in the next 5 to 10 years, because we've got many more doctors and nurses coming on stream. So I think that there is light at the end of the tunnel, but I completely recognise the picture that life is tough.
Just in the last point, it was quite interesting. Do you have faith in the NHS long-term workforce plan to generate that surplus of workforce, despite narratives of 40% wanting to leave the workforce before they even qualify, record numbers applying to the GMC to get their certificates to practice abroad, particular countries even looking at the NHS, it recognises it's a world-class service in training doctors, and they're sort of, in essence, poaching them, whether it's Canada or Australia. You still have faith in the NHS long-term workforce plan?
Well, it's chicken and egg, isn't it? I mean, one of the reasons it's stressful being a doctor is because we haven't been training enough doctors over many decades, and it's going to remain stressful until we increase the flow of new doctors coming in to relieve those pressures, and that is now happening. That was one of the, I think probably Rishi Sunak would say that's the thing he was most proud of doing as Prime Minister when it comes to the NHS. But we have to be honest with people, this isn't going to happen overnight. It does take 7 years to train a doctor. And, the last I heard was that Australia was no longer recruiting foreign doctors because they pretty much got the ones they need there. There may be other countries, but I think the NHS is unbeatable when it comes to the quality of clinical care and the things that you can learn inside the NHS and the values of the system. I mean, it's interesting that, Australia and Canada both have semi-privatized systems. So, the NHS, one of the reasons for the pressure in the NHS is because we don't charge people for walking through the doors. And I think that's actually a precious thing about the NHS.
Going back to your first book, you write, ultimately aiming for zero preventable harm is more than a tactic to raise ambition. It's also a statement of values within the NHS, like you say, to determine it as delivering a world-class service to bettering health and well-being for all. Given persistent variation in care, litigation fears that we've previously talked about, with resource constraints, what would it take for the NHS to officially, genuinely commit to zero avoidable harm, to work towards its ambition? You've mentioned a few things, but what do you consider to be the first concrete step towards this ambition?
Well, I think we've got to basically get back on the trajectory that we were before the pandemic. So if I give you an example, I got lots of things wrong, but, preventable harm went down over the 6 years I was health secretary. There were 4 million more patients in good or outstanding hospitals by the end of my time, which we weren't even measuring when I started. But if you look at, for example, perinatal deaths, extended perinatal deaths, the number of baby deaths overall was down by 15%, which is about 2 fewer deaths a day. And that was something that I think everyone involved in the efforts to improve maternity safety feels very proud about. That was about 6 years. Did the same again from now and reduced it by another 15% over the next 5 years, we would actually have the safest maternity care in Europe. So, that doesn't mean it'll be perfect, and there are still lots of things we need to get right. But when we decide we want to do something, we really do make progress. And the reason I have confidence that the NHS will do this is because I think that it is part of the NHS's core values to give the highest quality care to every single one of its patients. At its root, it is a service that puts patients before profit. And I think that the highest standards of patient safety is something that every NHS clinician really wants.
In your new book, you describe the NHS as a vital part of our soft power in Britain, noting its role in global health research, its reputation, as you've mentioned previously, for trust and equity. What do you mean particularly about that in terms of how can the NHS be leveraged as a diplomatic asset? What do you envision in it adding to our soft power as a country?
Well, I'll give you an example. Medicines and vaccines discovered in the UK saved more lives in the pandemic than those from any other country. About 6.3 million lives saved globally as a result of the discovery of dexamethasone and the Oxford AstraZeneca vaccine, which was made available with no intellectual property charge across the whole of the developed world. It was something we should be really, really proud of as a country. And Cambridge has become the European Centre for Life Sciences Research. So when it comes to things like preventing future pandemics, the hostility of the Trump administration to the World Health Organization, I think, indicates that we're not going to see much leadership on that front from the United States. There's a very big role for the UK to start thinking about what it is that we need to do, because we know that in this pandemic, believe it or not, we were quite lucky that we were able to find a vaccine and get it working within sort of 9 months. Now that, when we started the process of looking for a vaccine, people like Chris Whitty didn't think it'd be anything like that quick. But we actually had some work underway in a disease category that was similar to COVID, and we were able to piggyback on that research to get the vaccines to work. And we discovered that mRNA vaccines worked, which we didn't, I think, know before. So this is something where the UK does really, really well. And, the NHS could play a leading role.
You credit the motivation to writing your first book actually being inspired by Thatcher and learning about how she had time, even in her role as a prime minister, to receive and read and listen and learn from letters. And you wanted to change your practice and listen to the lived experience of patients going through the NHS. What is one story throughout your time and perhaps since then that has stayed with you, and what is the lesson that it has taught you?
I remember that the Cancer Drugs Fund was over budget, and so I was advised as Health Secretary that I should take off some of the drugs that were being offered on the Cancer Drugs Fund, because we were already spending 200 million a year more than the budget, and we would have to cut clinical care in other areas unless I did that. And so the advice was to take off some drugs that didn't save people's lives, but just prolonged life by 3 to 6 months, and say that those are not going to be available. So I approved that decision. And then a constituent came to me in a surgery, not knowing I'd made that decision, and said, I've got this cancer and there's a drug that the NHS used to offer, but they're not offering it anymore. And I just want to live long enough to see my daughter do her GCSEs this summer. I had to be honest and look that. And he was so decent about it, but I had to look him in the eye and say, well, I was the person who made that decision. And in the end, we found a way for him to be able to access that drug. It just reminded me that you take these very logical decisions at the top of the pyramid, but there's, real human beings who are affected by every single decision you take. And that's why when people say what was the most fun job I did, I would say Foreign Secretary, going around the world, red carpet treatment. What was the most powerful job? Chancellor, for sure. What was the job with the biggest emotional wrench? No doubt about it, being Health Secretary.
The future health workforce is grappling with various questions about its identity, its purpose, its value. What is a message that perhaps you would like to give to them from your experience as a health secretary, from your experience in writing this book? What is something that you want to resonate with them that you think should be heard?
Well, my daughter wants to be a pediatrician. She's just 13 years old, and I am thrilled that she wants to go into medicine and not become a politician. And I think that in the age of AI, the role of doctors will change, but we will still want doctors. And this is also going to be the age of longevity, and people are going to want to talk a lot more and have very close relationships with their physician as we navigate living for much longer than our parents and grandparents did. And I think it's going to be a brilliantly exciting profession that's going to be transformed by advances in medicine. So I think you're going to have a job for life in medicine. It's going to be fantastic. It is very stressful now, but stick with it, because I think there are going to be better days ahead.